Let's conclude our discussion of the temporal bone with a discussion of implants, reconstructions, and surgical findings that you're likely to see in the temporal bone. So here's a list of what we're about to run through. We'll spend some time on cochlear implants because radiologists play a large role in the assessment of cochlear implantation. We'll talk a little bit about tympanostomy tubes, which you just need to learn how to recognize. And then we'll discuss ossicular reconstructions. To understand ossicular reconstructions, you have to imagine the ossicular chain as grouped into an a malleoincudial group, a Stapes group, rather than three discrete ossicles. So when you take out just the malleoincudial complex and replace that, that's called a partial ossicular replacement prosthesis. When you take out all three of the ossicles, both components, then it's a total ossicular replacement prosthesis, or TORP. If you just replace the Stapes component, then that is a Stapes implant. We'll talk a little bit also about Incus Interposition, where we shorten the ossicular chain. If you're going to evaluate imaging on cochlear implants, you have to really understand the different components of the implant and how they work together. It's important to understand the situations where CT is most useful and where plain film is most useful. Bottom line, CT is useful in pre-procedural planning and for evaluation of chronic cases. Plain film is used predominantly in the operating room to ensure appropriate placement during the surgery. You need to understand what you're looking for in a pre-procedural planning CT, what the relative contraindications to placement of a cochlear implant are. And you need to know the different mechanisms by which the cochlear implant may fail or malfunction in order to identify these radiologically. So what are the components of a cochlear implant? First of all, there's an external component that sits outside the patient, and they can take this off and set it on the table, no problem. It has a microphone in it, it has some audio processing hardware and software, and it has a transmitter. That transmitter is sending signals to the internal component of the cochlear implant. The internal component is embedded in the skull. You carve a little divot in the skull and put this internal component in the skull. That has the receiver that the transmitter is sending to. And it's important to understand the external and internal components of the cochlear implant are held together with strong magnets. They each have a strong magnet, and when they're brought into vicinity of one another, they click into place, and that's how the transmitter and receiver line up appropriately. This has obvious implications for MR safety in that although the external component can be set on a table and left behind, the internal component can't, and that's a permanent magnet sitting in that internal component. You can see that that magnet on plain film, and you can ensure that it doesn't get displaced out of its appropriate position, especially after someone has had to go into an MRI. The whole issue of MR safety with regards to these cochlear implants is an evolving area and well beyond the scope of this lecture, but really interesting stuff. So after the internal component has received the signal, it sends it down a wire, and that electrode extends into the cochlea itself and winds up through the turns of the cochlea. The electrode has, in most models, 22 independently programmable leads so that different parts of the cochlea can be stimulated independently. You want at least 11 of those leads to find their way into the cochlea during implantation. Less than 11 and it gets hard to get good speech recognition. But more is better. If you end up with 22, that's great, as long as you've got at least 11. There are different types of implants with different numbers of leads. There are dual leads, for example, where instead of one electrode with 22 independently programmed leads, you get 2 with 11 each, and so there is some variation in the different types of implants. Before we do a cochlear implant, it's important to perform a pre-procedural planning CT. And we're talking about adults here. In kids, we usually use MRI because we're looking for cochlear nerve aplasia, as we have talked about before. But in adults, we're looking for different things. So in adults, our pre-procedural planning CT, here's a checklist of things that you should be looking for in addition to everything else you always look for on a temporal bone CT. It's important to comment on the degree of mastoid pneumatization. In order to get this electrode into the cochlea, you need to do a mastoidectomy and you need room to work inside there. So the degree of mastoid pneumatization is important. Additionally, the degree of aeration is important, and I distinguish these because if the patient has inflammatory disease in the mastoid air cells and or the middle ear cavity, that's a relative contraindication. You should at least be clearing that up before you go and put an implant through an infected area. The course of the facial nerve, very important. If the facial nerve is displaced in any way, it could be along the surgical tract. You don't want to accidentally injure the facial nerve. The Stapes footplate is important, although a separate cochleostomy is usually performed. Sometimes we go through the Stapes footplate, and you want to make sure that that's not sclerosed over. Get a sense of what the degree of sclerosis is at the windows. We want to look for inner ear anomalies. Particularly, we want to make sure that there's the right number of turns in the cochlea. We're about to insert something as far as possible into the cochlea. We need to know that it has the turns to accept that. If there's any previous history of labyrinthitis ossificans in particularly, it's obviously much harder, usually impossible, to put an electrode through an ossified labyrinth, so we need to know that ahead of time. That's not an absolute contraindication. There are some types of implants designed to deal with that problem. I think the thing that people most often overlook in the pre-procedural planning CTs is depression of the tegmen. You've got to go to those coronal images and look to see if the tegmen tympani has been displaced inferiorly due to chronic infection, for example, or due to chronically increased intracranial pressure. If the tegmen is in the way of the surgery, it makes it a much more difficult surgery, or even worse, violating the tegmen and finding yourself with a CSF leak is a bad outcome. So you don't want the tegmen in the way, or at least you want the surgeon aware of that. The plain film projection that we use to assess cochlear implants is called the modified Stenvers view. This is performed by turning the chin 45 degrees away from the side of interest. This brings the cochlea itself en face relative to the X-ray beam, and we can see that cochlear implant laid out as it curls up within the cochlea. So to orient you, here is the cochlear implant, the internal component embedded in the skull. This is the magnet we discussed. This is a ground lead, and this is the lead of interest. And you can see the individual electrodes that are along this wire. As we discussed, you can count them out. There should be 22 of them there, and of which we want 11 in the cochlea. This, by the way, is the contralateral cochlear implant in this patient. You can see the oval window is right about here, right? And so you can see that the majority of these electrodes are completely within the cochlea. And the idea is to count the number of electrodes that are successfully implanted and to communicate how many turns of the cochlea have lead in it. And so, for example, in this case, I'd say, well, we're not quite 360 degrees. Maybe we're at 270 degrees of implantation, where about 20 of the electrodes are within the cochlea. That's how I'd assess this implantation. And of course, I'd indicate that it was appropriately positioned within the cochlea itself. You can use CT to assess these implants, but it's tough. Usually reformatted images that mimic the plane of Stenver is useful. You have to be very careful. It looks like there might be a fracture of the wire right there. That is an artifact. The wire's thin and they have attachment points. It can be very difficult to assess. And it's also very difficult to assess the degree of curvature in the cochlea itself based on CT. Here is the Stenvers projection in that same patient. Much easier to assess. You can see that there are two leads implanted here, a dual lead, and this lower one is redundant upon itself, built up, and neither one of these is deep into the cochlea or able to turn within the cochlea. So this is actually a failed implantation. You have to look out for retraction of cochlear implants. Here is the lead coming in, and you can see that instead of curling within the cochlea right here, it has backed out, and there is redundancy of the lead within the middle ear cavity instead of curling within the cochlea. Here's an example where the lead has curled back on itself within the cochlea. We call that intralabyrinthine redundancy. You can see it's coming in right about here is where that oval window will be. You can see that this lucency is the cochlea itself, and it's going fine, and then it makes a U-turn, turns back on itself, heads the wrong way. So that's redundancy within the cochlea itself. You want to make sure that it is in the cochlea and not accidentally in the vestibule. The cochleostomy can lead in either of those two directions. Here the lead comes in. That's the cochlea. That lucency right there, that is the cochlea. But instead of heading nicely into the cochlea, this lead takes the wrong direction and heads off into the vestibule. So vestibular placement in this case. Here's what a fractured wire actually looks like. You can see this lead is headed into the basal turn of the cochlea right there, and then it comes out through the cochleostomy defect, and boom, it has immediate cutoff. That is a fractured wire. Be careful because there are areas of thinning and attachment of wires that can look like fractures if you're not careful, but when it has a complete failure to continue like this, that's when you want to call fracture of the lead. A displaced magnet is a really important thing for us to look for, and it's easy to identify on CT and on plain films, but it's easiest to demonstrate on plain films. This is the internal component, and this wire should have a round magnet right smack in the center of it. Is missing. There should be a radiodense magnet right in the center. Where is it? It's actually displaced down here. You can see the round object. It's overlying with the rest of the internal component down there. This round object should be centered perfectly within this wire ring. Displaced magnet. Okay, cochlear implants aren't the only way that we can assist surgically with hearing. There is a bone-anchored hearing aid that usually goes by the acronym BAHA. I think that this acronym can be confusing to people because it has nothing to do with the Spanish word. It's not below anything. It's just an acronym for bone-anchored hearing aid. And this is what a BAHA looks like. There's a screwed-in component that sits within the calvarium itself, and then there is a lead extending through the skin that attaches to a microphone, and we use bone transmission into the cochlea to assist with hearing. Tympanostomy tubes have a characteristic appearance that you just need to get used to and know what you're looking at and not be confused by them and think that it's some other sort of pathology. The tympanostomy tube has an open center and the walls are flanged. If you look carefully, you can see that these two parallel walls come out and then take a turn. They're flanged on the inner side and on the outer side so that they can't fall in and can't fall out. It's a characteristic appearance, and once you've seen a few of these, you won't be confused by them. Sometimes tympanostomy tubes end up in the wrong place despite those flanges. Here's an example where the tympanic membrane is here and the tympanostomy tube no longer traverses the tympanic membrane. It has fallen in, and that's going to need to be retrieved. If it falls out, it's less of a big deal. Sometimes they can get stuck to the walls of the EAC, but usually they just tumble right out and the patient never even notices. Let's talk about ossicular replacement prostheses. Here's where there's something wrong with the ossicles. They've got eroded by a cholesteatoma, for example, and you need to remove the ossicles and replace them with a surgical prosthesis that will play that same role of transmitting the sound waves from the tympanic membrane to the oval window. If you take out all three of the ossicles, the malleus, the incus, and the stapes, then you are doing a total ossicular replacement prosthesis, TORP. right? And what you end up with is a surgical implant that looks something like a thumbtack. It's got a broad head, that's what attaches to the tympanic membrane, and then it comes to a point, and that point, it's not a sharp point, that point is where we have carved off the Stapes footplate and replaced it with the prosthesis. There are many different brands, and they have slightly different radiologic appearances, but this is sort of the typical appearance for a total ossicular replacement prosthesis. Note that there is no stapes here. This prosthesis runs all the way from the tympanic membrane to the oval window. Total replacement. Here's what happens when a TORP gets displaced. You can see that it still has a thumbtack configuration, right? It's got a broad head and it comes to a point, but the head is supposed to be sitting on the tympanic membrane, and it's fallen away. The footplate is still right where it belongs, but it's not going to do much good if it's not connected to the tympanic membrane. Now, you've noticed that I'm showing you examples where you can see the TORP in all of its glory on a single image. That's not an accident. I've done reformatted images so that it always looks like that in these examples. Of course, if you don't do those reformatted images along the TORP itself, you're going to have to add it up in your head to get this appearance. Here's a partial ossicular replacement prosthesis. In this situation, instead of taking out all three ossicles, we've just taken out the malleoincudial complex, just the malleus and the incus. We've left the stapes behind. And so the partial ossicular replacement prosthesis, the PORP, runs from the tympanic membrane to the body of the stapes. And you can see that's exactly what it's doing here. It's got a broad head, and then it's got like little pinchers that are going to hold on to the stapes. Again, slightly different appearances for different brands of this, but that's the general idea. And this is a PORP in its appropriate position. Here's what a PORP looks like when it gets displaced. In this case, the head is still attached to the tympanic membrane. Ignore all that inflammation in the external auditory canal for a moment. The head is still attached to the tympanic membrane, but the foot is no longer attached to the stapes, which you can see right here. The PORP has been displaced off of the stapes. Stapes still in normal position. The third prosthesis that we can do to replace ossicles is called a Stapes prosthesis. In this situation, the malleoincudial complex is left alone, or left behind, and the stapes has been completely replaced. The stapes footplate has been taken down, and the stapes itself has been replaced. Here, the malleus and incus are still doing their job. They're transmitting sound waves, but now transmitting it to this device that connects from the incus to the oval window. These tend to look like little tiny wires. There's almost no discernible elements to a Stapes prosthesis. It looks like just a short metallic wire in that location. And this is its appropriate location where it's running. You can see the incutostapedial joint right there, and it's running to the Stapes footplate. That's what we like. Here's what happens when a Stapes prosthesis displaces. There's a couple of different ways that they can displace. They can fall off just like the TORP and the PORP examples that we just showed, or they can displace internally. And you can see that this Stapes looks like it has pierced through the oval window and is now sitting in the vestibule because that's exactly what it did. Now be careful. A Stapes prosthesis can look like it goes a little bit into the vestibule, and you have to get used to how far the tip of a Stapes prosthesis is permitted to go. This, for example, is way too far. This is displacement into the vestibule itself, but sometimes it looks like it goes in a little too far and it's still normal in appearance. You got to get used to what normal is. Here's an example of a Stapes prosthesis displacing in the opposite direction. Here, the Stapes prosthesis should sit upon that oval window where the Stapes footplate belongs. It may even look like it juts in a little bit, less than a millimeter, a little bit into the vestibule, but it should not be disconnected as in this case, and this one is displaced outward. Here's another example of a displaced Stapes prosthesis. Here you can see the head is still attached to the incus, so that part's okay, but the tip should be on the oval window right there. Should not have fallen back here into the sinus tympani. That's abnormal. It should be oriented more like this, and so this is another example of a displaced Stapes prosthesis. Another way of reconstructing the ossicles is to use an incus interposition. This, of course, only works if the incus is uninvolved in whatever process required you to reconstruct. Here we use the incus as the entire ossicular chain. You can see the tympanic membrane here, the oval window there, and there is a single bone running the entire length of the ossicular chain. That's the incus, and it's just been repurposed to be the entire ossicular chain. This is called incus interposition. And that's it. That's the last lecture on the radiology of the temporal bone. That brief review, according to my timer here, was 3 hours and 25 minutes. So if you got all the way through that, congratulations. Hopefully you know a little more about how to image the temporal bones.